Chairman, ladies and gentlemen, as every surgeon who is practicing with this field knows, the management of patients presenting with colorectal cancer and synchronous liver metastasis is complex. And this is because the lack of strong evidence about the appropriate sequence of treatment regarding both surgical interventions and the timing of chemotherapy. Nevertheless, the European Society of Medical Oncology introduced guidelines for the management of synchronous disease in 2012. The aim of our study is to undertake an audit of the management of colorectal cancer with synchronous liver metastasis in a tertiary center. In 1 year period, we discussed in our HBB-MDT 198 patients with colorectal cancer and liver metastasis. From these patients, 50 or 25% presented with synchronous disease, 63% presented with metachronous liver metastasis, and 12% had extrahepatic metastasis. A few words about patients' characteristics. The median age was 65 years old, with a predominance of male gender and a median BMI of 29. 66 of patients presented with colon cancer and 34 patients with rectal cancer. There was a balance between unilobar and bilobar liver disease, with a mean number of liver metastases 3 and mean size of the largest lesion 4.5 centimeters. Regarding the sequence of surgical treatment, 60% of our patients had their primary cancer operated first, followed by liver first 22% and synchronous resection 10%. From our 50 patients with synchronous disease, 54% had chemo plus minus radiotherapy first, and 46% had surgery first. As we can see from the numbers, in the first group, chemotherapy first group, patients that had primary first and liver first were about equal in number, whereas in the second group, surgery first, the patients that had their bowel operated first were the great majority of them, and this can be explained by the fact that most of these patients had their bowel operation in a peripheral hospital, and they were referred to our MDT afterwards. Continuing with the compliance with ESMO guidelines, all of the 17 patients that presented with rectal cancer had staging with pelvic MRI scan, which is compliance 100%. From then, 15 patients had clearly R0 resectable disease. So if we have a look here in the ESMO guidelines, all of them were T3 or T4 or node positive, so they belong to this category. And ESMO proposes from these patients 3 months preoperative FOLFOX chemotherapy plus preoperative radiotherapy, followed by surgery, followed by 3 months postoperative FOLFOX. So in our patients, 67% had preoperative radiotherapy, 86% had neoadjuvant chemotherapy, and from them 33% had chemotherapy with FOLFOX. Regarding colon cancer, from our 33 patients, 31 had clear ER0 resectable metastasis, and from those, 30 had single larger than 2 centimeters or multiple liver metastasis, and only one had single smaller than 2 centimeter metastasis. Here is the ESMO guidelines about synchronous colon cancer. So here, about the 30 patients with single larger than 2 centimeters or multiple liver metastasis, the guidelines of ESMO are the same: 3 months preoperative FOLFOX, followed by surgery, followed by 3 months postoperative FOLFOX. Our compliance was poorer in this case. Only 33% had neoadjuvant chemotherapy, followed, and 67% of them had chemotherapy with FOLFOX. This can be explained again by the fact that the majority of these patients were referred in our MDT in the middle of their treatment pathway. Regarding the unresectable disease, here our compliance was 100%. All of our patients had upfront downstaging chemotherapy. As a conclusion, this audit presents the complexity of the current management options for stage 4 colorectal cancer with synchronous liver-limited metastasis. It shows that implementation of the consensus guidelines proposed by ESMO is feasible. It reveals that compliance with these guidelines in the UK tertiary HPB referral center is only partial. And we can finally say that this is a predictable outcome considering that the current labyrinth of treatment pathways and the lack of randomized controlled trials. ESMO updated its guidelines in 2014, especially after the results of the EORTC 40983 randomized trial, which revealed no benefit in overall survival after perioperative chemotherapy. So the updated ESMO guidelines include no clear recommendation for perioperative chemotherapy. So as a final conclusion, we can say that only future randomized trials could provide strong evidence about the best treatment pathways for synchronous disease. Thank you for your attention.